So that study was led by Mark Hamilton and our group as part of a close collaboration with the Center for Cell Therapy at Stanford and Dr. David Miklos, focusing on the problem of not the efficacy of CAR T cells, but the unfortunate side effect of CAR T cells in patients who achieve cures of their lymphoma, but nevertheless have other risks, in particular non-relapse mortality associated with infections. So the study had multiple parts. The first was to see how high that risk was in looking at a group of patients treated at Stanford when comparing patients who received autologous transplantation versus CAR T cells in a propensity matched analysis. And this study confirmed that patients who received CAR T cells had higher risk of serious infections and death, with a significant fraction of that related to COVID, all within the same window and a sizable patient population for each of the two matched cohorts. With that in mind, the question was, what were the key driving influences? And we focused on patients who developed cytopenias or low blood counts and bone marrow biopsies. And we found in the majority of these patients, this was driven by clonal hematopoiesis with the operational definition of CHIP mutations above 2% in canonical genes being found in about 90% of them. And in having observed that, we wanted to know whether we could detect those abnormalities significantly ahead of the patients becoming profoundly cytopenic after CAR T-cell by looking at cell-free DNA. And this was done on some 800 samples from these patients. And there's some pretty dramatic results. So patients with CHIP could, by and large, be detected with cell-free DNA far before their time becoming cytopenic at enrollment into the study, and to have that risk captured. And then separately, doing clonal selection analysis, we found that those CHIP clones were growing or were pressured to expand while the lymphoma was shrinking, which is pretty remarkable. And so the next question is now what to do with this information for future patients. Do patients who have evidence of CHIP before starting CAR T cells, should they be managed differently to decrease their risk of serious infections and death beyond the existing measures that we have in place?